Hello and welcome to this webinar on the topic of managing challenging behaviors in individuals affected by SATB2-associated syndrome. This webinar has been made possible by a grant from the Child Neurology Foundation. Today I am joined by Dr. Caroline Richards of Richards Lab and Cerebra Network for Neurodevelopmental Disorders. Dr. Richards' current research with Cerebra Network is titled Profiling the Behavioral Phenotype of SATB2-associated syndrome. She will apply her work and research involving autism spectrum disorders and other genetic syndromes to help us navigate and manage increasing behaviors in our children. Welcome, Dr. Richards. Thank you for joining us.
Thank you very much for having me. It's a real honour to be with you today. And yeah, as you said, I'm Caroline. I'm an academic working at the University of Birmingham in the UK. And I'm also a clinical psychologist. And for the last 10 to 15 years, myself and colleagues have been working to try and understand behaviours that are shown in children with rare genetic conditions associated with an intellectual disability. So I'm going to be sharing a bit of our work today, specifically in relation to SATB2-associated syndrome. So thank you again for inviting me. And I think it's important to say at the start that I'm speaking on behalf of a group of us who've been working in this area. With my colleagues at the University of Birmingham, particularly Stacey Bissell, but also colleagues at other UK institutions, so Dr. Jane Waite, Dr. Hayley Crawford and Dr. Joe Moss. And together we've been working as the Cerebra Network for Neurodevelopmental Disorders. So we are a research team that spans a number of institutions. And our research agenda is really focused on trying to do research that has the potential to immediately improve the lives of children with severe and complex needs and their families. We're a really tight-knit team, and we were all trained by Professor Chris Oliver, who has an incredible legacy of research in this area. So I just wanted to flag at the start of my talk a few resources that you might want to go and explore. The first of which is a website called findresources.co.uk. And this is a dissemination website that we've set up, led by Jane Waite. It has information about a wide number of rare genetic syndromes, but it also has information that cuts across syndromes. So information about sleep, about behaviour, about mental health. And it is specifically focused on syndromes that are associated with an intellectual disability. So I think loads of the content on there will be really suitable and appropriate to you and your families. As it is the modern era, particularly now of online working, we have a Cerebra Network Twitter and Facebook group. Please do go ahead and follow us. So as I mentioned, we have the Find Resources webpage, and I just wanted to flash up a couple of screenshots of that if you do go to that website, so that you can see what you might find there. Critically, as I'm talking through this brief talk, a lot of the research literature that I draw upon can be found on this website, alongside videos of families and children and interactive videos from us as academics as well. We're also primarily funded by a research charity called Cerebra. And in our work with Cerebra, we have co-produced a series of guides for parents and professionals who work with children with intellectual disabilities. So I've flashed up their website there again, and you can download guides, for example, our guide on pain, on sleep, on anxiety. And a final plug is a website called ResearchGate. And on this website, we publish all of the academic papers that we have shared within the scientific community, but they're not published behind a paywall. So if you want to get at the original source data that I'm going to be talking about, there's a really good website to go to find those papers. If you search for any of our names, you'll be able to find a link there. So that's the kind of admin side. Hopefully that means you can now just sit and watch, knowing that if you want to go away and find any of those resources later, you can do so. So what I want to walk us through today is three key questions. So firstly, I want us to spend a little bit of time thinking about what are these problem behaviours, or behaviours that challenge, as we might call them in the UK, and how common are they? We'll be thinking a little bit there about some data we've collected with you on children and adults with SATB2-associated syndrome. And then I'm going to spend a good chunk of the session thinking about what causes these behaviours. And we'll think both about the idea that maybe these behaviours can be learnt, they might have an acquired function, and second, that they might be caused by internal causes that will be particularly important for us to assess in children and adults who might lack verbal language. And we'll spend a brief amount of time at the end thinking about how we can reduce these difficult behaviours. I want to stress at the outset that I am not going to be able to cover everything in relation to this topic. It is an area where there are some general principles that can be incredibly helpful, and I hope to share these today, but also sometimes where we require in-depth specialist support and assessment, and that's going to be beyond the scope of what we can cover in this session. So firstly, what are these behaviours that challenge and how common are they? We really like to use this definition by Eric Emerson to help guide our work. And quite some time ago, he defined challenging behaviours as behaviours that are culturally abnormal, of such intensity, frequency or duration that the physical safety of the person or of others is placed in serious jeopardy, or behaviours that might limit or deny access to the use of ordinary community facilities. Now, that's quite a broad definition, but it does help us to narrow down into some specific forms of behaviour. For example, we might think about aggressive behaviours towards others as falling within this definition. Equally, we might think about behaviours that someone might direct towards themselves that could cause them harm, self-injury. We might also think about screaming and shouting behaviours, non-compliance, destroying the environment. What's quite helpful in the definition from Eric Emerson, though, is that it might highlight for us that certain behaviours, whilst not desirable, are actually not necessarily challenging. They might be behaviours that cause some problems, but they're unlikely to place somebody in serious jeopardy or cause them harm or limit or deny their access to community facilities. And it's important that we narrow in on what we're talking about at the outset, because when we're thinking about potentially trying to reduce these behaviours, we need to make sure we're focusing on behaviours that are not just somewhat annoying or frustrating for us, but are actually behaviours that require intervention. So how common are these behaviours? Well, this is some data taken from a large study we did with colleagues in the UK, simply asking the question about how common are aggression, self-injury and destruction of property if you do or do not have an intellectual disability. And you can see from this graph here that nearly all of these behaviours are more common across early childhood if you have an intellectual or learning disability. So these are behaviours that happen in all populations, but they happen at a much greater rate when you also have a learning disability. In some more in-depth work led by Professor Chris Oliver across Birmingham, which is an area in the middle of the UK where we live and work, Chris and colleagues sought to find out within special schools, so these are schools for children who have a learning disability, who have an intellectual disability, how common are these specific types of behaviour? And you can see here that actually these behaviours are relatively common. So we're ranging from self-injurious behaviours at maybe 17% through to aggressive behaviours that are more common at 40%. I just want to highlight here that Chris and the team also asked about the severity of these behaviours and asked the clinicians and teachers to identify the children who were showing these behaviours at a significant level that was causing management difficulties. And I want to highlight this bottom group here. So there were about 15% of the children in this study that was showing at least one or more of these behaviours to a level that was causing a clinically significant problem. So this is not an insignificant group of children, and this has been a group of children that we've done quite a lot of additional research on to try and understand what might drive these behaviours. Something to note at the outset is that we know that self-injurious behaviours, aggressive behaviours, destruction of property, they occur at elevated rates in children and adults with an intellectual disability, and they also occur at increased rates when somebody has a rare neurogenetic syndrome. So here is some work that again was done by Chris and the team, and in this they compared a range of different rare genetic syndromes. So these abbreviations stand for Angelman syndrome, Prader-Willi syndrome, Cornelia de Lange syndrome, Fragile X, Prader-Willi, Lowe syndrome, and Smith-Magenis syndrome. I'm sure you've heard of some of those syndromes, but perhaps not all of them. The point here is that when we were thinking about self-injury as occurring in maybe 17 to 20% of individuals with a learning disability, we can see that the rates are much, much higher when people also have a rare genetic syndrome. And we can also run analysis to look at how much higher they are. So here our control sample is people who have an intellectual disability that doesn't have a genetic syndrome as the cause. And for example, here we see in Cornelia de Lange syndrome that self-injury is 6.5 times more likely if you have CDLS than if you just have an intellectual disability. And we see a very similar pattern for physical aggression. So this suggests to us that over and above intellectual disability being a risk factor for these behaviours that challenge, also having an additional genetic syndrome places children and adults at higher risk of showing some of these behaviours. Now, it's important to note here that we're not saying these are inevitable, but we are saying that the presence of these genetic syndromes does increase risk. And it doesn't increase risk uniformly. So I just want to point out here, Angelman syndrome, where the likelihood of aggression is over 3 times higher than in those with just an intellectual disability of no known cause. But there aren't strikingly higher rates of self-injury in Angelman syndrome. So it might be that specific syndromes confer risk for particular types of behaviours as well. Here's where I just want to highlight a little bit of the data we've collected with you about SATB2 syndrome. So this work was led by one of my postdocs, Dr. Stacey Bissell. And many of you will know this already because you've completed our quite substantive questionnaires. But we ran a large survey to try and understand a bit more about the profile of behaviours that might be present in SATB2-associated syndrome. And we were interested in asking developmental questions as well. So are behaviours, when they are present across different age groups? You'll see down here on the right that actually we got quite large samples. So we believe this is the largest study of behaviour ever to be conducted in SATB2-associated syndrome, and we plan to publish this later this year. So what did we find? Particularly in relation to behaviours that challenge, we found that these behaviours are actually quite common in SATB2. So we found rates of self-injury in the preschool group of around 40%, in the school age group of around 40%, and in the adult group, so although the bar is slightly lower here, these are the total numbers, but actually the percent in that group is higher. So 50% of adults were showing these behaviours. I think quite strikingly for us, and this really chimes with our clinical experience of talking with you as families, particularly the UK group, rates of aggression were very, very high. So at the lowest end, they were at 70% in the preschool group, ranging through to up to nearly 90% in the adult group. I'd also note here that we can't be sure about change over time because these are not the same children and adults in each group, so it's not a longitudinal study. But the fact that there isn't a big difference between early childhood rates and later childhood and adulthood does make us wonder whether these behaviours might also be quite persistent in SATB2 syndrome. And that's something that we need to do further work into. So this initial survey that we ran was helpful, we hope, in documenting a wide range of characteristics in SATB2, and we recorded another webinar earlier in the year, which I'm sure we can link to, that covered the majority of the findings from that study. But it was also really important in securing us onward funding to work with you as a family group. So I'm really excited to be able to say that Lauren Shelley has just started working with Jane Waite, one of the Cerebra network leaders at Aston University. And she's going to be doing a PhD that focuses entirely on SATB2-associated syndrome for the next 3 years. And the focus of that work is going to be on these behaviours that are really difficult to manage. So we're really excited to be able to keep working with you, and we really hope that this work is going to yield some important findings in understanding behaviour much more closely in SATB2-associated syndrome over the next few years. So that's a little bit about prevalence and a signpost towards hopefully some future research outcomes. For the remainder of the talk, I'm going to focus on drawing findings and conclusions from what we know in intellectual disability in general and thinking about how we can apply that to SATB2-associated syndrome. So why do these behaviours happen? Why are they occurring in children who have an intellectual disability? Well, one of our primary ways of understanding them is that these self-injurious or aggressive or destructive behaviours are in fact not purposeless or meaningless, but are actually behaviours that have become learnt by an individual over time. As psychologists, we talk about these as operant behaviours, behaviours that are sensitive to the environment around them. At a very simple level, this is what we mean. That these behaviours don't occur for no reason, but they occur predictably in response to antecedents or triggers in the environment, and that they are reinforced by the things that we do that follow the behaviour, so the consequences. So let me kind of unpack that a little bit more for you. I want you to imagine perhaps the child or adult that you care for, or another child or adult that you've worked with, shows a behaviour that we would consider challenging. As caregivers, adults, teachers and professionals around that individual, we find that behaviour aversive. It causes us worry, it causes us anxiety or distress. We're concerned. And motivated by that emotional state, we tend to do something. We tend to act. We might, in this instance, choose to engage with the child. So we might do a variety of different things. And I'm sure you've been through almost this list of things when you're caring for people. You might try and comfort them or offer something to distract them. You might try and occupy them with something, or you might tell them off. In some ways, regardless of what you've done, it doesn't necessarily matter which strategy you've chosen. What's critically important is that you've intentionally engaged with the child or adult, contingent on them showing that behaviour. And so from a psychological point of view, what we've effectively done is reward or potentially reinforce the behaviour. What that means is that in the future, it increases the likelihood of them showing the same behaviour. Let's imagine it was self-injurious behaviour in this instance. The next time that they're in the same situation. So the next time they encounter the same antecedent, the same need for somebody else to do or give them something, this challenging behaviour is much more likely to occur. Not as an intentional strategy. So we're not suggesting here that individuals are manipulating the environment around them, but rather because it was an effective behaviour previously, it becomes learnt. We all do this. We are more likely to do the things that are sort of rewarded and reinforced, and we're less likely to do the things that aren't rewarded or reinforced. So here what we call this cycle is a cycle of positive reinforcement. And the idea would be that the challenging behaviour over time, through repeated cycles like this, acquires a function. It acquires a purpose. And we might think in this instance of that purpose being, for instance, to gain attention from other people in the environment around that person. Or maybe to gain access to something, maybe a particular toy or a preferred object, or even something like food or drink. These behaviours, because of the way they are responded to in the environment, acquire a function. So this is a cycle of positive reinforcement, but we can also have the same cycle, but of negative reinforcement. In this instance, again, these behaviours occur and they're aversive, and so we act. Here, though, we might choose to disengage. So we might remove something. We might remove the individual from an environment. We might remove something from the environment from the individual. The key again here is that removal of something is reinforcing. And so the next time the individual with SATB2-associated syndrome is in a context where they need something to stop or be removed, that challenging behaviour is going to be more likely because it was reinforced previously. A really good example of this is thinking about our day-to-day lives with children when we perhaps ask a child to get ready to leave the house to go to school. Maybe we are asking them to help us put their coat on for them or to sit down so we can put their shoes on. When we do that, we're placing a demand on the child, and that might be difficult for them. And so they might go through a whole range of behaviours to try and get rid of that demand. A typically developing child might ask lots of questions, or they might say, "No, mummy, I don't want to do that." Or they might get up and walk away. A child with a more severe disability might have fewer behaviours available to them. And so what you might see is negative vocalisations or some rocking or repetitive behaviours. But you may then see an escalation into behaviours that we would consider challenging. And it might well be at that point, perhaps when the child has hit out or has bitten themselves or hurt a sibling, that we inadvertently remove the demand to put the shoes on, and we either do it ourselves for them or we find an alternative way around that situation. The key is that cycle, that contingent upon that behaviour, we have removed the demand. And so the next time the child is in the same situation, they're more likely to show that behaviour because it was effective in the past. I hope that kind of makes sense to you. A final component of this cycle is that we've seen that the cycle operates for the child, but we also know that same kind of cycle is happening for us as adults or as caregivers. So now I want you to imagine you're in the context of being the adult rather than the child in the cycle. And you've just seen a child show a very difficult behaviour. It's, as we've discussed, really frustrating or worrying or distressing. And so we act. And again, at this point, it doesn't matter whether we've engaged or disengaged. What's critical is that the child's behaviour then stops when we've reinforced it. And so we are reinforced. Our actions are negatively reinforced by the removal of the behaviour that challenges. And so we also are more likely to remove that demand or to go over and comfort the child, whatever it was that worked, the next time we see the behaviour. And so you end up with these interlocking cycles where we might have a child who's receiving a high degree of reinforcement or reward, but we also have adults and caregivers who are being reinforced by the removal of that behaviour. In this instance, our group do a lot of research on sleep. We finally get access to that reinforcing consequence, 30 minutes of unbroken sleep. And so we're more likely to bring the child into our bed. So we know these cycles occur, but they're really, really important because they are often the linchpin for us understanding why these behaviours happen. They change our perspective, so we don't see them as purposeless or as meaningless anymore. We see them as functional, and therefore that can help to guide us in thinking about how we might try to reduce them. I focus mainly on environmental reinforcement that involves another person, but those cycles of negative and positive reinforcement can also happen internally for a child. So, for instance, if you have very low levels of stimulation in your environment, you might show stereotype behaviours, rocking behaviours, or even self-injurious behaviours that increase levels of sensory stimulation, and those behaviours are then positively reinforced. They're more likely to happen in the future because they brought stimulation into the environment internally. So I've focused on those external environmental cycles, but they can happen internally as well. So the key here is that behaviours can be learnt over time, and there might be key themes we would attend to here, that they might be behaviours that help to gain access to attention or tangible objects in the environment, to escape from situations or demands or sensory input, and they might be behaviours that function to access automatic reinforcement or internal reinforcement via sensory stimulation. The one thing I would want everyone to take away from this section, though, is that this learning process is not intentional, neither on behalf of the child with a learning disability, but neither on behalf of the adult either. We are not intentionally teaching these behaviours. It's just that through that process of back and forth, they become learnt. Okay, so that was something about the idea that these behaviours can be learnt, but I also trailed at the front that there can also be internal causes for these behaviours. What about those? Well, I want to show you a few bits of data that we've collected over the last few years in children with rare syndromes. So first, here's some data on children with tuberous sclerosis complex. Again, another rare genetically determined syndrome. And in this study, Kate Eden, as part of her PhD, used a measure of non-verbal behaviours that are associated with pain. And all she did in this graph here is compare the frequency of these non-verbal behaviours that are associated with pain in those children who do and don't show self-injury. And what she quite convincingly demonstrates here is that pain-related behaviours are much more likely in the children who show self-injury than in the children who don't. A second really similar piece of evidence here in Cornelia de Lange syndrome, again another rare neurogenetic disorder. Cornelia de Lange syndrome is heavily associated with gastroesophageal reflux. And we've worked with the CDLS group over the last 20 years to develop a checklist of behaviours that we very often see when children have very painful reflux. When children have this condition, the acid in the stomach comes up the esophagus, and because in this syndrome children have very weak esophageal sphincters, the acid doesn't stay in the stomach but instead comes up the esophagus and can burn away in the throat and esophagus. And when that happens, we see a variety of behaviours. We see back arching, we see fidgeting and wriggling, excess salivation. We often see coughing, gagging, regurgitating. You would expect to see that with reflux. But also what we nearly always see is a strong association between these reflux-related behaviours and self-injury. So here we've moved from general pain indicators in tuberous sclerosis complex to specific indicators of reflux in a different syndrome, but note that we see exactly the same pattern. These behaviours are much more likely when somebody has self-injury, suggesting that there might be an underlying association between pain and particularly self-injury here rather than aggression or destruction per se. One final bit of evidence, and this is in autism, and not in autism where there's a genetic condition, but just in idiopathic autism. In this group, we looked to model what predicts both the occurrence of self-injury and the occurrence of the most severe self-injury. We found a number of risk markers, but for the purposes of this talk, I just want to highlight that the presence of a physical health condition, things like inner ear infections, stomach and gut problems, predicted both the presence of self-injury with an odds of almost 2.5 times more likely, and predicted the most severe self-injury at over 3.5 times more likely when people had a painful health condition. So what do we think is going on here? Well, what we hypothesize to be happening is that when somebody is in pain or discomfort, and particularly where they have lower levels of expressive communication, where they might struggle to clearly communicate to somebody else discomfort that they are in, these behaviours might directly lead to challenging behaviour. And that could be, in the case of self-injury, behaviours that target the site of the pain. So we might see picking at the chest when somebody has gastroesophageal reflux. We might see head banging or punching when somebody has an inner ear infection. Critically, we don't ever forget that learning cycle. So what we think is that pain can sometimes be the route by which these behaviours first get into the repertoire, and then through that operant learning cycle, they then might acquire additional functions in the environment. But pain might be one route by which these behaviours first start. Pain might also act to change some of this cycle. So the idea here is that when you are in pain, the demands that might be placed on you, or the aversive antecedents, whatever they are, become more aversive. I'm sure we've all experienced this when we've been unwell and we've had to do something that we don't really want to do. Our motivation to escape that demand is much higher because of the pain. So it might be that pain acts, here we would call that as a setting event, that increases the likelihood of challenging behaviour, because the reward here, escape from this difficult task, is so much more amplified because of the context of pain. Finally, though, I just want to highlight, particularly in relation to self-injury, an important factor. So those previous two examples would explain self-injury that occurs at the site of the painful health condition. But we often see self-injury that targets a different body part. So in Cornelia-de-Lange syndrome, for example, we often see children hair pulling or head banging when they have reflux, and that when that reflux is treated, the hair pulling and head banging goes away, but it never targeted particularly the site of the pain. And the way we've understood this is to apply something called pain gate theory. So the idea here is that when we have a physical disorder that causes pain, the signals of that pain travel to our brain along a number of different fibres in the body, and we receive that signal of pain. But it is actually possible to gate that signal or to block it. And we believe that some of the acute experiences of self-injury might serve to block or gate some of those experiences of chronic pain. Again, let me just give you a real-world example here. Imagine you walked through a narrow door frame and you caught your elbow or your knee on that door frame. You've got that real searing experience of pain. What's probably the first thing you do? Well, most likely the first thing you do is rub at it really hard. So what you're doing there is stimulating A delta fibres that block or gate that immediate experience of pain. And so taking this back into Cornelia-de-Lange syndrome, when children are hair pulling, what we think they are doing is blocking or gating temporarily that experience of pain coming up the esophagus from the reflux. So the take-home point here is that if you see changes in self-injurious behaviour, but also in aggression or destruction, you must first think about whether this could be caused by something like pain or discomfort. And we should do thorough checks for that, both at the site of any self-injurious behaviour, but also more generally across that individual's body and healthcare in general. The key problem, which I've alluded to with health problems and pain for children and adults who have an intellectual disability, is that there are a number of complex steps when we have a painful health condition. We first have to identify that the sensation that we're feeling is pain, and we need to locate it in our body. That interoceptive experience is actually quite challenging. Secondly, we have to be able to accurately label it. So we need to know that that experience is called pain and not called hot or called uncomfortable or called tired. Now, again, that might seem quite obvious, but actually that ability to accurately label that internal experience is complex. And we then have to take a final step in communicating that to somebody else. So here we need perhaps the verbal or non-verbal expressive communication in order to do that. But we also need to have the kind of theory of mind to know that if I tell somebody else about my pain, they might be able to help me. I hope you can see here why for children with an intellectual disability, for children with expressive speech problems, at every step of this process, they are less likely to both identify, label and communicate pain and painful health conditions. I focused on pain and discomfort as key internal causes of behaviours that challenge, but they're unlikely to be the only ones. So we also know that extreme tiredness, low mood, anxiety can all function as internal triggers to behaviours that challenge. I haven't got time to go into the ways in which these associations might occur, but these are a key focus for our research as the Cerebra network, and I direct you to a number of the sources I mentioned at the beginning if you want to read more about those. Okay, I'm going to finish now very briefly by just thinking a bit about how we can reduce behaviours that challenge. And the critical part here is that the cart cannot come before the horse. So interventions will only work if they're preceded by assessments that correctly identify the cause of behaviour. A huge part of our work as clinical psychologists is very often about getting that assessment right, and many of the interventions we need can then just come off the shelf once we've identified the right cause. So what this often takes is a lot of time, careful, systematic behaviour monitoring. And we have to be willing to act almost as scientists, discovering data that might either confirm or in fact disconfirm our initial ideas about the cause of behaviour. It's critical here that we seek support as well. This is complex psychological work, and very often we need clinicians and services around us to help support our assessment of why these behaviours are happening. When we've identified that ABC pattern, what the trigger is, how it leads to the behaviour and how it's maintained by those reinforcing consequences, as I said, we actually know an awful lot about what we can do to intervene. In the UK, we have NICE guidance. These are nationally published health and care guidelines around interventions in behaviours that challenge. And these tell us about what services should be doing after they've done these kind of functional assessments, once they know what the purpose of the behaviour is. Very briefly, we can think about interventions at the level of the antecedent. So, for instance, if you have a behaviour that occurs predictably when attention is low in the environment and is maintained by somebody coming over and giving attention to the child, you can run interventions that simply increase the availability of adult attention. You can use a kitchen timer that dings every 5 minutes to remind you to go away and attend to the child or adult that you're caring for. If it's to do with demanding tasks, we sometimes think about how we might alter those tasks. Can we completely remove them? Or can we reduce complexity or difficulty? Some people show behaviours that are triggered by changes in the environment. In that case, we might think about introducing things like visual schedules to make the antecedents much more predictable and reduce that change to routine. We can also run interventions that target the behaviour. So remember, these behaviours are not purposeless or meaningless, they are functional. And if they serve a function for somebody, we shouldn't just want to remove them, we should want that individual to have an alternative means by which they can communicate that need or preference to the environment around them. The key intervention there is something called functional communication training. Excellent speech and language therapists are your best friends here, but also clinical psychologists who can help you to develop a functional communication intervention. We can also, as probably a last resort, think about how we are responding and either try to reduce or remove the reinforcement that we're delivering. One of the things I'd encourage all parents and carers to do is to try, if they see behaviours that challenge, to respond intentionally. Because actually, if we think about that cycle, what very often happens is that these are unintentional responses on our behalf. So we rush over, rightly so, to make sure children are safe, to protect them, to keep them physically safe. But if we can just take a moment to be mindful of our responses, We might find there are ways of, say, keeping a child safe and protected, but not giving that contingent attention alongside it, so that we're not inadvertently reinforcing the behaviour. So for behaviours that are learnt, where we've identified what the function is, there are a wide variety of interventions that can be introduced. But what about for those behaviours that are motivated by an internal state? Well, ultimately, interventions for most physical health problems are available. We know how to treat ear infections. Not me personally, I'm a psychologist, not a paediatrician, but I hear these are pretty straightforward to treat. We give antibiotics, right? The challenge is knowing that our child with an intellectual disability is in pain or discomfort. And one of the great tools there are standardised measures that use children's behaviour rather than their verbal speech to indicate that they're in pain. Just one of the ones I want to signpost you to here is a scale called the Face, Legs, Activity, Cry and Consolability Pain Scale, or FLAC pain scale. It is as simple as this infographic suggests. You rate those 5 areas: face, legs, activity, cry and consolability on a scale of 0 to 2. And the score you obtain has been standardised, and if you have a higher score, it's more likely that the child or adult with a learning disability is in pain. You can freely download this from our funders website, cerebra.org.uk. It's something I'd really encourage all parents to have a copy of. What's critical is getting to know your child's pain signature. So we would encourage you to use this when your child is well, and when you know they have a health condition that's causing them pain, and for you to get familiar with what those differences are, so that those can be communicated to everybody who works with or cares for that person. I'd also highlight a number of other guides on sleep and anxiety that are also on the Cerebra website that might help you work through how to assess and intervene in other internal causes of behaviour. A final resource that I want to signpost you to today is something that we've just published last week, led by Chris Oliver and a wide team of us who've worked at Birmingham and in the Cerebra network for neurodevelopmental disorders. This is the Be Well checklist, and we worked really hard on that acronym. This is the behaviour and well-being of children and adults with severe intellectual disability and complex needs checklist. This checklist is freely available on ResearchGate, and it walks you through the things that we think should be in place for children and adults who have an intellectual disability in order to ensure good well-being and reductions in behaviours that challenge. So to close, what should you do? I've given you a lot of information. Where do you start? Well, this is the order in which I work through things. We would always start by, if an individual has a known syndrome like SATB2-associated syndrome, in finding out more about that syndrome. And here, the best resource is your family support groups, the groups that have set up this webinar today and have publicised it to you on social media. Meet with other families and find out more about the syndrome. Particularly in the cases of behaviours that challenge, make sure you know about health conditions that are common in that syndrome. Be assertive about getting referrals and support when needed, and get advice from local doctors and health professionals on pain relief. Thirdly, think about those background factors. Think about mood, hunger, fatigue, anxiety. We want to make sure that that all of those are in the most positive place possible in order to make sure that those background contextual factors aren't causing behaviours that challenge. Once you are sure about all of those things, so pain and discomfort and those internal triggers, then set about assessing the environmental factors, the antecedents, behaviours and consequences. And you may well need advice and support from clinical psychology or others who have training in behavioural approaches to do those assessments and to do those interventions. It's really critical as you start moving down that path to keep good records and evaluate what you do. Make sure you try things consistently and persistently, and make sure you collect data on whether it's working or not, because it's really easy in the midst of an intervention to feel like it's not making any difference. Make sure that you have specific goals with small steps that are located in individuals. Who's going to do what next for your child? Who's responsible for doing something, and when will they have done it by? Make sure you have systems in place that can review progress towards improving outcomes. And the final thing I would end with is that we, as families and professionals working with individuals with an intellectual disability, need buckets of tenacity and pretty aggressive advocacy at times. Ultimately, our position is that it doesn't have to be like this for the children and adults that we work with. We shouldn't accept that they will just show these behaviours, that they might be in pain, that they might have sleep problems that are untreated. So we have to carry a big stick and work hard with the professionals around us to make sure that we are doing everything we can to achieve the best outcomes for our young people and adults. I'll just finish by saying a big thank you to my lab group and team, to the SATB2-associated syndrome in the UK and in the US, to our funders and collaborators. And there's a few extra reference points there for Twitter and Facebook and our website. Thank you very much.
Thank you so much. We are going to move on now to a brief question and answer session. And our families have lots of questions on this topic. And a lot of it, I think, is just a need for ideas. One question that I wanted to start with before we jump into specific questions is, it seems like our kids show behaviors that increase as they start getting older. Any ideas as to why that's the case for our kiddos?
Yeah, so we definitely see in the cross-sectional data that I presented at the beginning that these behaviours don't drop away in a way that we might have expected. I guess my primary reason for thinking that is that I would go back to that cycle of operant learning, that these behaviours are functional. And so we shouldn't expect them to go away because the children and adults are going to be encountering those same antecedents. So unless we have taught them alternative communicative strategies for requesting attention or a game or getting a break from a task, those more challenging behaviours are of course going to pop up again because we as adults will reliably respond to those behaviours. So a key intervention strategy is thinking about not just reducing behaviours that challenge it, but actually replacing them with functionally equivalent communicative behaviours. These can be things as simple as like pressing a button that gives a vocalisation like, I need a break. And we teach children to press that. We respond to that much more reliably and predictably than their challenging behaviour. And then we would expect the challenging behaviour to decrease. So the key for me is that if the behaviours aren't going away, then perhaps the functions haven't been addressed. It's also possible that there might be biological drivers and SATB2 specific drivers for these behaviours, and that's a big focus of Lauren's PhD. So we hope that we will find out more about that in the next few years.
Sounds like there's a lot more to come, and that's super exciting.
Yeah.
So jumping into some of the more specific behaviors that some of our families have seen, one thing that I saw across the board very frequently in this, when I asked for questions, is our kiddos seem to need attention at all times. So they are constantly needing a parent's attention, need to be touching or running their fingers through the parent's hair, or sorry, my screen. And so I'm seeing not accepting no, not understanding personal space, things like that. So any ideas for ways to reduce that kind of behavior?
Okay, so that's really, really tricky. We've worked with two other rare genetic syndromes that immediately come to mind where we see we would term it heightened motivation for social contact. So a higher than average drive to engage, often with a primary caregiver in these other two syndromes, or a preferred individual. It's usually an adult, not another child. And that, as a parent, as a caregiver, is incredibly demanding. It's incredibly time consuming. And perhaps, unfortunately, it's quite challenging to intervene with as well. So the two other syndromes where we see this are called Smith-Magenis syndrome and Angelman syndrome. I just want to focus particularly on Angelman syndrome because there's a real parallel with SATB2-associated syndrome. So some of your families probably have already reported that Angelman syndrome was a potential diagnosis that was considered, right? So children with Angelman syndrome rarely develop any expressive language. So there's a real similarity there. They also often have severe to profound intellectual disability and this very strong motivation for a primary caregiver. Some work done by Mary Heald, one of our colleagues at the University of Birmingham. She ran a small intervention with a group of children with Angelman syndrome where she did something called discrimination training. So the idea here was, can we teach children to learn when adult attention is available and when it isn't? Because actually it's not simply the kind of constant request for attention that parents reported as being really challenging. It's the fact that it's at times where it's just impossible. You know, you're cooking dinner or you're attending to another child. So she ran this study where she wore a really bright high-vis jacket. And when she was wearing that jacket, she didn't respond to the children's sort of requests for attention. And in children with Angelman syndrome, this was primarily aggressive behaviours and quite often hair pulling. So she sat often for sort of 40, 50 trials, and the children pulled her hair and she didn't respond when the jacket was on. And then when the jacket was off, there was an immediate response. Now, what she demonstrated in this very small group of children was that over time, the children learnt to discriminate. And so when the jacket was on, the requests for attention went down. But when the jacket was off, the requests for attention were there. So this is a really small kind of proof of principle study, but it demonstrated to us that it is possible to start developing behavioural interventions that might signal to children when that adult attention is available. So that's one strategy I might think about. That needs much more testing and has never been trialled in SATB2-associated syndrome. But the other thing I would mention is you mentioned about the children liking to play with adults' hair. And I guess one of the things I'd be thinking about is sensory stimulation as well. So could it be that part of what they are gaining from that interaction is about the sensory experience? And can you replicate that in a way that doesn't involve you as a parent? So could you have a really big stuffed doll that has like hair-like material that they can run their fingers through that maybe they might play with instead if you need a break or if you need to get on with something else? Again, that's just an idea, and that is totally off the top of my head. I might have parents sort of shaking their head at the screen saying that'll never work. But these are kind of things that I think are worth considering.
Great. Thank you. Another question commonly is that how do you respond when a kid is having a meltdown, just a full-fledged meltdown? How do we help them calm down when they're not self-regulating there?
Yeah. So I think being very mindful of the operant model, that everything that we do after children show these behaviours could reinforce the behaviour, so it could make it more likely in the future. What we critically need to know is what the function is. And there are times where these behaviours are very much attention maintained. So they cease when attention is then given. So in that instance, I would want to be very careful about how I responded. And I might almost use quite a cold approach in which I might make sure the child is safe. So I might physically be present with them, but I might not give them lots of eye contact and lots of social interaction until the behaviour had stopped, so that I'm not reinforcing that pairing of social attention with responding to the behaviour. The thing I would note, though, is that there are times where children have these kind of meltdowns or emotional outbursts, and your response and your attention doesn't stop it. And it's like they've gone beyond the kind of function, but actually there's an element of dysregulation in emotion and behaviour. And there are a couple of other syndromes we work with where we see that really commonly. We don't know in SATB2-associated syndrome, but in those other groups, we think that that might be to do with problems at a cognitive level that children have with their own executive functions, with their ability to stop and start and regulate their behaviour. And if that is the case, your response might be quite different, because your contingent attention might actually have no impact on the behaviour if it's simply that the child has lost control. And in those instances, ideally, we want to stop that from happening in the first place. So we might want to work on emotion regulation strategies and triggers for those meltdowns. But also, we might be much more socially attentive when we do respond, because it might not be so important to moderate the social attention that's given in those instances. And so we might sit very close and comfort them and engage in social contact, if that helps them to re-regulate. It might be that they're the kind of child that actually needs space and time and quiet in order to become more regulated. And some of that is a bit kind of trial and error, I think.
I heard you mentioned clinical psychologist, functional communication training, specialists that might have that our families could reach out to for one-on-one help with specific behaviors or problems. How do we know if we are finding a clinical psychologist that has experience with children with special needs or accessibility needs?
Yeah, so in the US, I would be thinking about whether or not people are registered as applied behaviour analysts, ABA therapists, because a lot of the work around functional behavioural interventions is derived from ABA type approaches. So I'd want people to have a good grounding in those techniques. In the UK and the US, I would also look for BA-BCP accreditation. So are people accredited with the I've forgotten what the acronym stands for now, which is inevitable, isn't it? But the council that provide accreditation around behavioural assessment and intervention. So when kind of identifying a registered provider to help support your child or adult, I would want to look into their credentials and just make sure they've got experience, and then have a conversation with them. And I think you guys know your family members the best, and you also probably get a good sense when you meet somebody, if another professional, if they have got the right kind of approach, if they're going to understand the needs of your child. Clearly, they are unlikely to have met another child or adult with SATB2-associated syndrome. And this is commonly an experience of the families we work with, that you have to do a huge amount of education yourselves of the professionals around you. But some of the approaches I've talked about cut across kind of regardless of syndrome. So actually knowing about SATB2-associated syndrome isn't a prerequisite for being able to deliver a really good functional assessment and intervention.
Okay. I have a couple more questions. One of them I think will be brief. As far as pharmaceutical interventions for behaviors, I know that you're not prescribing medications to patients personally, but do you have any research or resources where families could look at different medical options for managing behavior? Like some things that people have brought up were like CBD oil, propranolol, different medications to manage behaviors. Any thoughts on that?
So I'm going to be quite careful here, because I'm not a medic. I don't prescribe medication, and particularly in the UK, we have had a real problem of over medication of people with intellectual disabilities, often with very strong psychoactive medication. So in the UK, there is a strong history of people being prescribed antipsychotic medication, which obviously have significant side effects. And psychologists are very often working with prescribers to help try and reduce that prescription. What I will say is that, to my knowledge, there have been no randomized controlled trials that specifically look at reductions in self-injury, aggression, or destruction of property in response to any medication. So what they often look at is a kind of cluster overall behaviour that they often term irritability. And that's where we draw our evidence base for medications. So there's some problems with that. I guess the other point I'd want to make is that some of the medications you listed there, and in fact all medications that are used, they aren't targeting behaviour, they're targeting what we think is the potential cause. So propranolol, for example, I know is commonly used to treat anxiety. If we think the function of that person's behaviour is anxiety, if we think that the trigger for a person's behaviour is anxiety, then as with any typically developing person, of course they should have treatment for their anxiety. That treatment might be psychological, so it might be behavioural strategies, or it might be medication based. But just as a person without an intellectual disability deserves any underlying mental health treatment condition to be treated, so does a person with an intellectual disability. But what I'd want to be really clear on is whether you think the medication is treating the behaviour or the cause. And to the best of my knowledge, there is no medication that specifically treats behaviours that challenge. They treat underlying causes. And so that idea there is about, again, making sure you're very clear about what the cause is.
That makes a lot of sense, actually. And then the final question, I think, for today is, can you touch on what discipline? I know that's a very broad-ranging topic, but getting our kids' behaviors, discipline, like what do we do? Where do we get started on that sort of?
So do you mean they're about kind of really trying to reduce behaviours that challenge, or
trying to teach them to break bad habits, things like that, when a typical timeout may not be effective?
Yeah.
Yeah.
So, yeah. Often when we're working with children who have additional needs, we have to be much more sensitive and much more conscious of our approaches than you do with a typically developing child. You can get away with a whole host of kind of error in your approaches when you have a typically developing child. And I think that is less the case when you have a child with an intellectual disability. So I think the key for me would be about that question about what is the function. And if you can work out what is triggering the behaviour, then you can think about carefully how you intervene. So timeout's a great example. It's often lauded as like the solution to all parenting problems, right? They've been naughty, sit them on the naughty step, give them a timeout. Timeout is negative punishment, so it's the removal of attention in the hope that it will make the behaviour go away. That will only work if the behaviour was reinforced by attention, if the behaviour functioned to obtain attention. So if the behaviour functions to obtain food, or to remove a demand, or to get rid of a bright sensory input in the environment, putting a child in timeout teaches them nothing. What I would also say is that interventions that target the consequences, so that's what timeout is, it's an intervention that manipulates the consequence, may not be the best approach for our children and families, because what it doesn't do is it doesn't teach the child a strategy to get their needs met. And actually, if we believe these behaviours are functional, they are useful, they are purposeful, our question has to be, how do we help our children and young people to obtain that function or purpose or need without using those behaviours? And so then we've got to think about what behaviour could replace it. So rather than them pulling on my arm when they need my attention? Can I teach them? Can I model that they put their hand over my hand to request my attention instead, for instance? You know, are there simple things we can do that still allow them to get their needs met, that you can reliably reinforce? So that's where I'd start, but I'd also say it is a hard process, and to my mind, this isn't something parents should be doing on their own. I do live in a sort of mental utopia where I sort of wish and hope that all parents had access to the services that they need, because I do think you should be supported in doing this. But I appreciate that not everyone has that. And so I guess I'd signpost you then to some of the resources that I've highlighted, which will go into what I've talked about in much more detail and might give you some ideas of where to start.
Well, Dr. Richards, I appreciate your time so very much. On behalf of the SATB2 Gene Foundation, I'd like to thank you and hope that as this new research is done and comes out, that our families can benefit even more. Thank you so much for the time you put into helping our foundation understand behaviors for our children.
No, not at all. It's been an absolute joy, and we will certainly be in contact in the future.
Thank you so much.